I have a special guest today, Dr. Jared Wallen. He was on our podcast a few weeks ago, and I'm super excited to have him on. Super knowledgeable, great urologist. I learned a lot of information from him, so you guys will really, really enjoy all the information you're going to get from him. Clinical expert in so many different ways in his field, and we're kind of going to just kind of tag team, piggyback each other on these. I have some expertise as a pharmacist, and he has a lot of expertise as a doctor. So that's what we're gonna do today. So go ahead and go to the first slide. So why testosterone? So benefits of testosterone. So probably the number one, I wouldn't say the number one reason, but possibly when it comes to men and women is we think about testosterone for libido. And that is a great reason. There's nothing wrong with that. There's a great reason to prescribe testosterone. But there's many other things too. So bone density, for instance, testosterone is the ultimate bone building hormone. We talk about estradiol. We talk about estrogens all the time for women, and we think about estrogens when we think about bones. But estrogens really, estradiol specifically, really only decrease bone loss. So they decrease osteoclast activity. Osteoclasts break down bones. Estradiol helps to decrease their activity. So it helps to decrease bone breakdown, which means it does not build new bone. So testosterone actually is anabolic. It builds new bone. It is the best anabolic bone building hormone around for sure. So it's great for that. So, and maintain lean body mass. We always, think about testosterone with muscle mass, and it's not that you necessarily have to be big like a bodybuilder or power lifter. That's not necessarily what testosterone necessarily does. I mean, if you do progressive resistance and lift weights, you might get that way. But lean body mass in general is important. And as we age, because our testosterone level goes down, our lean body mass goes down. So that's why, and our lean body mass is so important for so many functions. I mean, to keep our metabolism high, to keep us strong, to keep our structures strong, and to protect us from injury. So very important there. And improved mood. Testosterone is a mood elevator, period. There are many men that get into their 40s and all of a sudden they're depressed. Well, they don't necessarily lack fluoxetine, which is a brand name Prozac, but what do? We prescribe them Prozac. So maybe they need testosterone because it definitely improves their mood. Cardiovascular benefits. So testosterone definitely lowers cholesterol. It lowers total cholesterol. There again, let's use the middle-aged man example. Middle-aged man comes into the doctor's office and has a cholesterol of 240 for the first time in his life. His cholesterol is high. And so what do they do? What do we normally do? What's the standard of care? The standard of care is to prescribe a statin. When in reality, if you check his testosterone, he might have a testosterone deficiency. Thyroid's important also when it comes to cholesterol. Maintain skin and hair health. Quality of life. Quality of life is really, really important. Let's face it. Andropause, I just put that on there because andropause is basically the male menopause. I just want to mention that because sometimes that comes up. So I just want to educate you guys that if you see that, that's kind of what that means. So Dr. Wallen, do you have any other comments on that slide?
Yeah, I mean, I think you mentioned a lot of great benefits. You mentioned the cardiovascular benefits and the cholesterol standpoint, but one of the ways I think that patients really can wrap their brain around how and why testosterone is good. Remember, your heart is a big muscle, right? And you mentioned that testosterone is one of the best molecules out there for muscle function and muscle strength and et cetera. And so, knowing that the heart is a big muscle, testosterone certainly plays a good role in the heart function. And remember, part of the reason that cholesterol plays a role in that is that, cholesterol, especially when it's high, is what, kind of clogs up arteries and limits blood flow to muscles. And certainly the heart is, again, a muscle. So, that's the heart attack, right? If you have a blockage in the blood vessel because of cholesterol deposits or what have you, the muscle gets a lack of blood flow, lack of oxygen, and then, kind of starts to die off in certain areas. So yeah, I mean, I think that's the biggest thing that I would expand upon, but certainly the hormone has many, many benefits throughout our entire body.
And let's just go let's just keep going on that. This is just kind of an extended slide of that. What if we had a medication? What if there was a medication invented that would increase bone density, lower the risk of breast cancer? And if you guys want references for this, I've got references for this. Relieve anxiety and depression, increase libido, increase muscle mass, decrease fatty tissue. The list goes on. What if we had a medication like that? How much would that medication be worth? And look at on those diseases, how many medications we prescribed. So to treat or prevent those diseases. So what if we had a medication, i.e. testosterone, to treat those diseases? I mean, what would a medication be worth? Go ahead and go to the next slide.
And Shawn, I would just counter you with that. What would a normal hormone be worth that does all those things? Because that's what testosterone is. Remember, it's a normal hormone that's in your body. That's what makes us men is testosterone. That's why we're not women, because we have more testosterone from the testicles, and ultimately, that changes a lot of things in our body. But again, it's a normal hormone. Yes, it may be either, depending on the formulation, maybe made in a lab or not. I mean, there are plant-based derivatives out there that are, completely bioidentical to the typical formulations that your body creates as well, right? So, I think that is something that, kind of helps people feel a little bit at ease about the use of testosterone as a replacement for, their natural hormone production that is no longer occurring in their body.
Right. And that's really all we're doing. We're just trying to replace a hormone that, a natural hormone, the same exact molecular structure that's in our body just doesn't produce as much anymore. Our bodies, usually after mid to late 30s in males, our testosterone levels, even in males a lot earlier, because our testosterone levels definitely peaked during the mid-puberty, late puberty years, in their 20s. But it maintains a pretty consistent level up until our mid to late 30s, and it starts to decline. And typically, we don't see a lot of symptoms until men get into their 40s and even 50s a lot of times, unless you got, like Dr. Wallen, you're really looking for some of those things. So yeah, you're right. It's just we're trying to replace at a normal level that you're not producing anymore. So this slide is just just talks more about those benefits. Another thing, for women, and I mean, you can speak to men. I'm not sure about incontinence in men if you see testosterone being an issue with that. I'm not sure, but for women, testosterone is, works wonders to treat incontinence. It might be partly because it you can apply it topically and it converts to estradiol, but I know that it just you see that. So
well, I think that the other part about that is that, again, going back to the muscular part of things, incontinence is highly related to pelvic floor dysfunction in both men and women, right? And so if you're increasing the tone of the muscles or the strength of the muscles in the pelvis, and certainly remember, part of the problem that women have after they have childbirth, when the fetus moves through the birth canal, that certainly stretches out a lot of muscles and et cetera, right? So part of the problem that women have is, and one of the ways that we help them is through pelvic floor physical therapy for both men and women with urination issues or leakage or what have you. And so if you're kind of adding a little supplement into there to kind of continue to actually also strengthen those muscles, certainly that's theoretically certainly could be a way that it would help as well.
Absolutely. And thank you for that input. And that's why I have a doctor on with me, because those are things I definitely don't know as a pharmacist. Well, I do want to hit on this slide a little bit. Aches and pains. I will tell you, I have, a handful of anecdotal examples of patients that were on opioids and they were having knee pain, for instance. At least one of them had knee pain, and she started testosterone replacement, and her knee pain went away. I mean, testosterone, I think there's a lot of theory there about how that might be. Is it a brain issue because testosterone makes us feel better and it helps with depression and, it stimulates other hormones and neurotransmitters? Or is it a functional issue with, testosterone increasing, the muscle structure? Not really sure, but I will tell you anecdotally, I've seen a lot of patients that have gotten their pains went away when they went on testosterone. Do you have any comment there, Dr. Wallen?
Yeah, I do. I mean, ultimately, remember you already said it once this morning. Testosterone's a bone builder too, right? And
All right.
osteoarthritis is a lot of times breaking down of the edges of the
Yep.
bones and what have you. And so, I mean, there are some studies out there that show that you can see up to an eightfold, an 8 times increase in bone growth, new growth with hormone replacement. And actually, Larry Lipschultz's group, Alex Tatum, a couple of the guys out there, they put together a paper actually they kind of look more at a nandrolone, which is a derivative of testosterone, and kind of compared that to testosterone. But and they said that might be a little bit better from a bone pain standpoint. But I think they saw upwards of a 50% decrease in bone pain from the folks that they replaced their hormones in that series. So I mean, again, just like you said, if you can come off of your strong pain medications because you're replacing a natural hormone, especially when those pain medications could be addictive and cause a lot of other problems like constipation and et cetera. I mean, that's huge for a patient's changing their life, right?
Absolutely. Yeah, absolutely. So go ahead and let's go to the next slide. So I'll let Dr. Wallen speak on this.
Right. So this is just a parlay into this doctor listed here, Dr. Dananoa. Excuse me for probably mispronouncing his name, but he's actually an endocrinologist, and actually I think he's like the chief of endocrinology at Baylor, University of Baylor. Or not sorry, not Baylor, University of Buffalo. That is. But this slide just speaks to, we talked about fat mass and lean muscle mass. And remember, a lot of those are related to diabetes as well, right? And so a lot of the problems we see related to type 2 diabetes is extra fat mass and obesity in the populations. But basically, this is in response to, this is an article that he published just online in Helio, but this is in response to his observation that 30% of roughly 1/3 of diabetics actually also are hypogonadal or have low testosterone. And further, a series out of Germany with Dr. Saad and the rest of his group, they showed that about 30% of the folks that were hypogonadal and diabetic, or again low testosterone and diabetic, for the folks that they replaced their testosterone, about 30% of those actually went into remission of their diabetes, meaning they no longer had diabetes. They were able to come off their metformin, their insulin, etc. Now, remember, diabetes didn't develop overnight. It doesn't go away overnight. It does take some time. But compared to a control group that had 0% remission of their diabetes, and both groups were on diet and exercise type regimens and that type of stuff, so certainly again, remember testosterone is a metabolic hormone. And part of the problem with extra fat mass, obesity, our metabolism slows down. We can't break down the sugars. Your blood sugar increases, or your blood sugar increases because you can't break them down and use them, and you're not burning through them, and so it just kind of adds extra fat to your body, basically. Again, when you replace that hormone to a kind of a more normal level, remember your metabolism starts to kick up again, and you start able to kind of speeding up these processes with this hormone that help you shed fat, increase lean muscle mass, and again, significant changes in people's lives. I mean, again, there's no other diabetes medication on the market. You're the pharmacist, Shawn. You tell me, is there another diabetes medication on the market that reverses diabetes?
No, and there's a
I
lot. Yeah, there's not, and I will be honest with you, Dr. Wallen. In our practice, I am not a believer in long-term diabetes medication for type 2 diabetes, because
right.
I'm a big believer in treating the problem, not just treating the symptoms. And pretty much any medication, any diabetes medication, and honestly, I don't even know a lot about the newer ones, but still, when you look at it, their overall goal is to lower blood sugar. Well, there's so many more things going on with diabetes, the overall inflammation of diabetes and the other effects. Like, for instance, sometimes you don't even get diagnosed with diabetes because your blood sugar is not high enough, but they don't even check insulin levels. We know people that are definitely obese and they don't qualify for being a diabetic, but I wonder what their insulin levels are, because there's a lot of stuff going on in there. And really, in reality, let's treat the problem. Let's check their testosterone. Let's get their hormones balanced. And obviously, it's a piece of the puzzle. They
Right.
still need to change their diet, just like you were talking about, change their diet, change their lifestyle. But I don't honestly believe that a type 2 diabetes medication is really going to fix the problem long term. It's just treating the symptom of high blood sugar. So
Right.
yeah, and testosterone, let's not even, obviously we've mentioned this, but testosterone has so many other benefits. I don't, metformin doesn't have another benefit of, like testosterone does. I mean, so anyway, but yeah, we
Right.
can talk about that for a long time. So go ahead and go to the next slide, Lindsay. So I do want to make it clear, and I think the people that have joined us, and a lot of other healthcare professionals and doctors, they probably know that testosterone is not just for men. But I will tell you, when I first started doing this in my practice 20 some years ago, it was kind of, I had to educate some doctors that women need testosterone also. So women make testosterone from their ovaries, just like men do from their testes. And if a woman's had a total hysterectomy or she's went through menopause, she's definitely not making as much testosterone anymore. So our goal of when we replace women is to replace them, just like we talked about earlier. We replace a man's testosterone to what their level was. We don't go, super physiological. Same thing with a woman. And in general, there's a lot of different research you can see here, but in general, a woman needs 10 to 100 times less of a dose than a man, and that's just as a man's dose is variable, a woman's dose is too. So in general, that's what we do with women. So women need testosterone, just not as much, but prevents urinary tract infections, vaginal atrophy. Remember, I told you there's not a better bone building hormone. Testosterone is anabolic. Well, guess what? That's the same thing with atrophic vaginitis. Testosterone is anabolic. What do you got? You've got atrophy of tissue is what you've got. So you want to build that tissue back up. Testosterone is perfect for that. Reverses incontinence. Dr. Wallen already talked a little bit about that. And of course, increases arousal and sensation. Dr. Wallen, I would love your comment on this slide.
Right. I mean, I think classically we use estrogen a lot for vaginal atrophy. I mean, I think you mentioned that a lot of times testosterone is converted to estrogen in the tissues, especially in fat cells and et cetera, in the female, and also to some extent in the male. So certainly that makes sense. What you mentioned, the anabolic nature. What other problem do most older females have other than recurrent UTIs is osteoporosis, right? And so again, strengthening back those bones, rather than adding them onto any number of slew of brittle bone medications that are out there. Quite honestly, I don't prescribe them, so I don't even know the names of them off the top of my head. But again, and the other thing is, you mentioned it a little bit from a functional status, but remember, the other part of getting old that's a little bit difficult for both men and women is the balance, right? And so, strengthening the muscles, strengthening the bones, certainly helps with functional standpoint from keeping them, balanced so that they're not, breaking their wrist or breaking a knee or an elbow or whatever when they fall, and kind of continuing to preserve their health overall, right?
Yeah, absolutely. And I think we have a case study in here. We're going to be talking about this, but just in case, I want to mention it because you talked about the bone building, the standard general medications we prescribe for osteoporosis. One of the first ones to come out was Fosamax, and Fosamax will increase T scores. It builds new bone, and it'll increase T scores. So that's a good way to measure for osteoporosis. But one thing they found out is that the new bone that it builds is brittle bone. Our bone needs to be turned over. So that's why we need a hormone symphony. We need estradiol working with progesterone, working with testosterone, because estradiol decreases osteoclast function, progesterone, testosterone increases osteoblast function. You need the turnover, breakdown, and new bone builds. And Fosamax doesn't really do that like the hormones do. So what they found out is that Fosamax was increasing T scores by building new bone, but it's actually brittle bone. And if you want an example of this, when you go to a dentist, especially, well, actually probably any dentist that's going to possibly pull your teeth, which is any dentist, they have you ask that you fill out a form that they ask if you're on any medication. If you're on one of those medications, and there's multiple ones now, like Fosamax, if you're on one of those medications for osteoporosis, they will refuse to pull your teeth, because what they found out is that they were pulling these people's teeth and they were shattering their jaws, because the new bone that was built also built weakened their, was brittle jaw muscle or jawbone. So that's just an example of how when instead of treating osteoporosis with a drug like Fosamax, what's the problem in the first place? Well, they had a lack of hormones. So let's fix the problem, not just treat the symptom. So hopefully that wasn't too much of a little sideways on our presentation, but I wanted to make sure I got in. I want to make sure I got that in there. Go ahead. All right, Dr. Wall, I'll let you talk about this slide.
Right. So this slide actually looks at the 2018 AUA, American Urological Association guidelines for testosterone therapy. And we talked about, usually most physicians will end up, screening patients for hormone, deprivation or hormone loss or low testosterone or what have you because of symptoms, whether they come in with insomnia or fatigue or low libido or, you name it, whatever their symptom is that we end up deciding to check labs about. This actually is specifically, you can see it towards the end of it, towards the end of the red highlighted part. In the absence of symptoms, the American Urologic Association still recommends the following people to still be screened for low hormone levels: those with unexplained anemia, bone density loss, diabetes, exposure to chemotherapy, testicular radiation, HIV/AIDS, chronic narcotic use, those opioids that we talked about earlier.
Yeah, right.
Male infertility, sexual dysfunction, pituitary dysfunction, and or chronic corticosteroid use. And so, which is, can be used for a lot of different things. But so, I mean, the reality is that they're saying that even with the absence of symptoms, you should, if they have these problems, anemia, again, I remember testosterone is a potent actor in the bone marrow to increase red blood cells and increase the oxygen carrying capacity of your tissues, which is why a lot of these athletes will abuse it, because they can increase their stamina, their performance, because they have so much more oxygen to their tissues. They can create longer lasting and more strength in that manner. And so especially even for folks who have chronic renal failure, or for folks who are HIV/AIDS, they tend to have a lot of dysfunction there, or any number of other different problems. But again, a whole list of people. I mean, you could potentially, in my clinic, I could potentially find one of these reasons in about 50% of the people that walk in the door, probably.
Well,
and so,
I was going to even ask you that question. And now, so in your experience or your knowledge of the industry and for urologists, is this happening in practice?
that's a great question. I would say probably not. I mean, again, it depends on the state, but I mean, I think more and more we're getting there. Actually, I was just reading. So the beginning of this update actually says that, somewhere around 25% of folks, were never even getting blood draws before they started on testosterone therapy, which seems ludicrous to me. Which is part of the reason that they make these guidelines, to kind of standardize the industry, right? But so, the reality is that, before this 2018 guideline, I mean, I think, even as recent, I think we talked about this before the last time we had the webinar, even as recent as 2015, testosterone replacement or testosterone hormone therapy was kind of poo-pooed because of, risk of cardiovascular dysfunction. Even had a black box warning on the label that said that it could potentially cause heart attacks or strokes, which, the American Urologic Association and endocrine societies and such have done a lot of research since, and basically said that there's really no strong evidence that that's true. And so that's since been removed and reversed. And again, I think we talked about earlier, the benefits to the muscle and to your lipids and cholesterol issues, that testosterone can have, the hormone replacement. Again, actually, this same guideline 2018 says specifically, if you have low testosterone, it's an independent risk factor for bad cardiovascular or heart outcomes. So it means,
right,
potentially something's going to go wrong with your heart if you continue to go on with low testosterone levels.
And that makes complete sense to me. I always thought about the heart, testosterone causing heart attack thing, and I'm like, it didn't ever made sense to me, because if testosterone caused heart attacks, 19-year-old men would be getting heart attacks.
Right.
And I think what a lot of that study where the black box warning was on put on some of the testosterone products was just a classic association does not prove causation. So
Right.
my opinion is that if you've had low testosterone for 20 years and then all of a sudden you're 65 years old and a doctor puts you on testosterone and you have a heart attack, you can't necessarily blame it on testosterone. I mean, the cardiovascular damage has been done for 20 years. So in reality, if you would have been started, in my opinion, if you would have been started on testosterone earlier, you would have prevented that cardiovascular damage in the first place, and you might not have had a heart attack. That's kind of my rationale when I think about testosterone and heart attacks. And that's what I tell, when I'm educating other doctors or patients about it. That's kind of what I say. So I don't know if you have a comment on that at all, Dr. Wallen.
Well, I mean, I think, yeah, I do. I think it goes back to, the cholesterols and the blood vessels. Remember, a heart attack is a blockage of a blood vessel, or either complete or in majority of it, over 70% or better, right? And so that limits the blood flow to a specific area of muscle tissue. The muscle tissue dies off. But so if you have, like you said, if you have a 65-year-old who's been low testosterone for 25 years, and his cholesterol's all out of whack because of it, even if he's on the statin or not, and what have you, he's not all that active because he's fatigued and doesn't feel that well. I mean, if your blood vessel is kind of clogged and narrow, and we replace your testosterone and get you back on the hormone, you feel young and chipper again, but your blood vessel is still narrow. You start pumping, and all of a sudden you have a situation where you really can't pump enough blood to the muscle, and you end up with a heart attack, right? And
Right.
so, again, I mean, there's actually even the same guideline says there's really no association with blood clots or venous thromboembolism type events in testosterone use. I mean, I think that you certainly have to be careful, because we'll talk about it here, I think, in a little bit, that if you are on some of the longer acting forms of testosterone, you do get polycythemic, meaning your red blood cell count increases, right? And so if if your blood cell count gets high enough, then your blood actually gets thick. And actually, Zandra commented here, said that their dad had a stroke about 8 years ago because of testosterone. Again, I think that there's really no evidence to say that cardiovascular or potential neurovascular compromise occurs with the hormone itself. But if you're not monitoring the CBC, if you're not monitoring the hematocrit and closely following, it kind of goes back to you were mentioning. These hormones do, I mean, we're not looking for super physiologic goals here. We're looking for normal hormone function, normal hormone replacement to normal physiologic levels. I've actually spoken with a few doctors who have concerns about hormone therapy, and they're mentioning some folks who are doing therapies that are well beyond normal hormone levels, and I don't certainly agree with that at all. But I think replacing a natural hormone to your normal level, and making sure you're getting a checkup with your physician or whoever is prescribing that for you. And certainly, I mean, I usually check when I start someone on testosterone. I check labs about 4 to 6 weeks afterwards, and then at least twice a year after that. And so you got to follow these people and make sure that you're keeping them safe by making sure that their blood isn't getting too thick because they're producing so many red blood cells, or other types of issues, to make sure that we prevent the bad problems. And again, it's like you said, correlation or association there does not always actually mean that one thing or the other truly caused the problem, right?
Right.
So,
and let's talk about labs and H&H and CBC a little bit later on, when in a slide.
right.
I think we'll talk about that, and I've got lots of questions for you.
Yeah, absolutely.
So let's talk about the different ways to replace testosterone. I think injections probably, I'm not going to say the most popular anymore, but it might be the most common, most popular. When testosterone, when we first isolated it back in the 1940s, we found out it wasn't absorbed orally very well, which means when you swallow it, it's not absorbed very well orally. And I will say that it's not absorbed orally. it's just that it's not absorbed very well because our stomach, we have what's called a first pass through. Our stomach and our intestinal tract and the liver will metabolize it. So actually, testosterone will work orally for women because you don't need as high a dose for women. For men, it is like impossible because you would need way too much testosterone to do it orally, and it just probably wouldn't work. So when somebody asks me about one of the disadvantages of injections, what would the biggest disadvantage? The first thing I say is, well, it's an injection. And I usually get a chuckle out of that because it is true, though. It's an injection. So it is a minorly invasive procedure at that, but it is still invasive. So you got to do an injection. So you either have to go to a doctor's office or the doctor teaches you how to do the injections. And one of the problems with injections is that you get what's called peaks and valleys. So you get highs and you get lows. So, and I know that, like if you look at the package insert of depot testosterone, it is indicated for once a month injection. And I'm going to get Dr. Wallen's input on this a little bit later. But, once a month injection, as you can imagine, you're going to have a high peak for a few days, and then you're going to have lows for weeks. So, and I think doctors have figured that out, and we figured that out. So we started doing twice a month injections, and then to get the not as high peaks and not as low valleys. But then even it's like twice a week injections, and to lessen those peaks and valleys. So here's the problem with that, though. You still get a peak. You still get a peak right after injection, and you will still get a valley before the next injection. So, and when our bodies produce testosterone, our bodies normally produce testosterone in what's called a diurnal variation. So a daily variation. Produce testosterone the most during the morning, and then it slowly goes down throughout the day, and then lower in the night when we should be sleeping. So the testosterone is preparing our bodies to deal with all the stress that we have during the day. So, and that goes through a daily function because we're diurnal mammals, right? So when you try to do twice a week injections, it's not following that diurnal pattern. So you could argue, well, could you do it daily? Well, you could, and that even adds up more costs. You've got more syringe costs, and it does require another injection every day. But here's the issue: you still have an immediate peak after injection. And I debated one time with a endocrinologist who just loved injections, and she would do twice a week injections. And I asked her, I said, so have you ever done a blood draw like an hour after they got their injection? And she said, no. And she says, that's ridiculous. It's because it'd be really high. And I'm like, okay, that's my point. So, right. And when we get high peaks, testosterone will convert more to other things. So our body will say, oh, we got too high a level. Let's convert to something else. So it either converts to estradiol or converts to DHT, dihydroxytestosterone. Both are good, but not necessarily good at too high a level. Too much estradiol, and as men, we can get what's called gynecomastia. Gynecomastia is, like we would grow breasts and we would get, hold more body fat. We would, if you've seen a man with gynecomastia, it looks like they're getting some woman features. So we want to prevent that, obviously. DHT, there's been association with DHT with prostate cancer, and I'm going to let Dr. Wallen talk about that, and DHT with male pattern baldness. So before I forget, Dr. Wallen, go ahead and hit on that.
Yeah, I mean, there's a lot of newer research out, even estrogen. Obviously, prostate cancer is something, it's most common solid organ cancer in men, just behind skin cancer, right? And so 1 in 8 men will be diagnosed at some point in their lives. It's the jury's still out as far as, kind of what specific, estrogen abnormalities, DHT abnormalities, certainly play a role. But yeah, you're right. The hormones certainly are highly being investigated for problems there. Like you said, DHT does. I mean, in fact, one of the Propecia actually basically inhibits the
Right.
formation of DHT, right? And so, the other thing is, remember, one of the common medications that I never use, but is used in some practices, is finasteride, which also inhibits the formation of DHT. Which, remember, what that does is it basically limits prostate tissue growth to some extent. And so, again, that kind of just correlates back to Because remember, what cancer cells are is the abnormal cell cycle regulation to where they can just divide and divide and divide and divide, and all of a sudden you have a mass, right? And so, certainly the fact that DHT or inhibition of DHT limits the growth of the prostate, certainly does give us some indication that it could be involved in those cell cycle progression and what have you. And so if it does come unchecked or unregulated, then that can certainly be a problem. Like you said, I mean, estrogen, in excess, remember, it's not only do we want to replace the testosterone, but we want to make sure that there's about a 20-to-1 ratio of testosterone to estrogen in a male. And so, from that standpoint, we don't want your estrogen to be zero, because there is some evidence that suggests
Absolutely.
low levels of testosterone, or low levels of estrogen rather, are good for your heart. But we also don't want that creeping up, because number one, gynecomastia, like you mentioned, but high estrogen also does cause a lot of the same side effects as low testosterone does. A lot of the same symptoms can come about if your
That's right.
estrogens are too high, right? So certainly, it's not there's no one size fits all for any of this, which, kind of going back to these injections, like you were mentioning, the diurnal variation, where you kind of get one peak in the morning and a smaller peak in the afternoon. You basically, if you're doing an injection once a week, which I think is nowadays probably the most common
Yeah.
formulation for an injection, you basically bypass all of that, and you get an injection or you get a peak once a week, and then you kind of slowly drift down. There are, actually, I did want to update you. There's actually a new oral formulation of testosterone that's out on the market. Previously, you're right that the dosages were high enough that we were concerned about liver failure issues, and that's why oral testosterones were off the market. But there's a new one. It's called Jatenzo. I think obviously because it's new, it's a bit pricey. But that is out there on the market. But the reality is, again, some of these longer acting, they don't necessarily work like your normal body cycles typically do, and so that causes problems. Even the injections, we'd be remiss if we didn't bring up the fact that typically if you're on testosterone, especially any of the longer acting testosterones, even up to even as short as once a week or twice a week, typically they're going to blunt your ability to produce sperm. And so you basically will become infertile. And so, certainly if there's any men out there that are interested in hormone replacement or, maximization of their hormones and have low issues or and symptoms, that's a consideration, because if you give yourself an injection once a week, typically what it does is it tells your brain that, hey, I've already got enough, I don't need to produce anymore. And that also actually tells your brain that the second signal that comes from your brain is FSH down to the testicles, and that's what tells your testicles to make sperm. And so, if your brain basically shuts that down when you get exogenous testosterone through an injection, and so from that standpoint, basically you become infertile. There is actually a newer formulation, which I don't think that you have a slide for. I forgot to mention and bring it up, but there is a newer little nasal spray that's actually done 3 times a day, that actually has been shown to have pretty good results at actually preserving fertility while still replacing the testosterone. Because again, and actually I asked the company about that, why 3 times a day? Why couldn't you make it where it's more of, like a normal body process, where it's diurnal peaks twice a day, once in the morning, once a little bit, smaller in the afternoon? They couldn't give me a great answer, but regardless, it's good at preserving fertility. Again, unfortunately, because it's a newer medication, it's
It's
still
really expensive.
a little
Yeah.
bit harder on the pocketbook, right? So
Yeah.
that's the way that big pharma works, unfortunately, in this day and age.
Well, thank you for bringing up both those, the oral testosterone and the nasal testosterone. And I will remember to talk about those more often when I talk about testosterone. The nasal testosterone coming from, without doing a lot of research on it, coming from a pharmacist perspective. So obviously you're going to get great absorption in the nose.
Right.
It's a mucous membrane, great blood flow. So you're going to get great absorption, bypasses first pass. Here's one of the problems. Anytime you get into a mucous membrane, you get super fast absorption. And, testosterone doesn't have a long half-life. So that's why they're dosed at 3 times a day. Obviously, there's a big problem with having to dose something 3 times a day. It's
Right.
hard to get patients to use something twice a day. 3 times a day would be very, very difficult. So that would be, other than price, that would probably be a compliance issue there.
Right.
So let's go back on testosterone injection. It's usually thought of as being one of the least expensive ways to deliver testosterone because the injection's been around forever. So they're generic and usually inexpensive. But when you start looking at costs of disposable syringes, and if they are going to the doctor to get it, which Dr. Wallen can speak on that a little bit, it does increase the price. So there are, it's not just a drug cost you have to look at. Will you talk, Dr. Wallen, on how many of your patients would get it in the office or in other offices also, and other providers' offices? What do you know about that?
Yeah, I mean, I think it's less common. Certainly if folks have needle phobias, but certainly want to do the injections. I mean, again, like you mentioned, typically the injections, I think they've been around so long that they're generic, and most insurances are they've kind of vetted them and that type of thing. And so from that standpoint, I think that's one of the reasons that they've been kind of used more than other formulations. But yeah, I mean, if you're coming into the office, usually you may get a nursing visit charge, or potentially even an injection or medication delivery charge in the office, which certainly, other than just the medication, is going to increase your costs. And so from that standpoint, again, it's not something we typically do a lot of teaching and training, either with the patient or with their partner, or whoever, to try to get them as autonomous as possible. There is also a kind of a longer acting injection. The trade name, I guess, is Avid, which basically is an 11-week injection where you would come into the office and get that done once every 11 weeks. But again, that basically kind of completely blunts the typical normal body processes, normal cycles. And again, like we kind of mentioned earlier, between you and I think both of our brains are connected in the fact that if we're trying to replace normal hormones, we the best way to probably do that is in a normal cycle, the way the body normally does it, right? To try to get function to as normal as possible, rather than here's a whole bunch of testosterone and you can chew it up over 10 or 12 weeks,
Right.
and we'll see you back then. I mean, it's convenient, and like you mentioned with the nasal spray 3 times a day. I mean, listen, sometimes I have trouble getting people to take a medicine once a day, or once a week, right? So I mean, it's the reality. Like, we all forget, and sometimes even just grabbing your cell phone and making yourself a little alarm, whatever you got to do to help yourself. But it's hard. I mean, we're all busy. We all have other things going on. It's not always easy to just be like, oh, hey, and some of these things, some medicines have to be refrigerated, and that type of thing, right? Which limits your ability to kind of transport it with you and carry it, or so
Absolutely.
it's a very complex.
Yep.
So
So let's go to the next slide, producer. So another way to deliver testosterone is by pellet insertion. Testosterone pellet. They're sub-Q. They're inserted sub-Q. I'll have Dr. Wallen talk about the procedure a little bit later. They're inserted under the skin. Has to be done in the provider's office. It does require a scalpel, and special training. I've witnessed quite a few of the procedures, and I've actually went to some training that some doctors have went to, and I observed it, and they always talk about it. It's funny because the person that was doing the training, she's done thousands and thousands of them, and she was talking about what an easy procedure it was. And of course, I'm watching, and I'm a pharmacist, and I'm like, that does not look easy to me. I mean, but she did make it look very easy, and I'm sure to a surgeon like yourself, Dr. Wallen, it's a pretty simple procedure, but it can deliver, at least in men, usually not in women. Not that we can't do it in women, but usually the women pellets usually only do a lot smaller dose, and it usually only lasts 3 to 4 months. But in men, it can last up to 6 months. There again, once the pellets are inserted, they're inserted. They're there. You cannot. It is very almost impossible to take them out. I've heard of doctors trying to do it, and it just doesn't work very well. Does not follow diurnal variation. It's like all of a big dose at once. Now they do dissolve slowly over time, so it's not all at once, but it is definitely an invasive procedure. There is a chance of infection. The office procedure can be pretty expensive because it does require a little minor surgery, I guess we would call it. One of the issues with it too is that the pellets can fall out. I know a lot of doctors will put 1 or 2 stitches in, maybe. I'm not sure what Dr. Wallen does. With active patients, they're pretty difficult because if you're a bike rider like myself, I ride a bike 6 days a week, and I want you to kind of be away from exercise for like 6 days or at least a week. That's just not going to happen. If you scar easily, you can see people that have done a lot of pellet procedures, they have little scars. So those scars start adding up. And not just for active patients, but also for not just for bike riders or active patients, but for people that travel a lot. So sitting on an airplane afterwards is not recommended, or sitting in a car a long time. They are a great option. If there is no other option for just, if they do not want to do any kind of daily testosterone, and they're because they're non-compliant or what have you, it's a great option for that, I believe. What else am I forgetting? I think that's about it. Here's one of the things: you're kind of guessing what the dose is going to be at first. So you might underdose or overdose somebody at first. I mean, typically we try to be conservative, so we'd rather underdose them. But if that's the case, those pellets are there for 6 months. You can't. So if you underdose them, you'd have to add some kind of testosterone afterwards to get their level up. So, Dr. Wallen, do you want to discuss the procedure a little bit?
Yeah, sure, absolutely. And quickly, actually, I think Zandra asked another question about kind of what the schedule for testosterone is for women. I think we'll get to that here in a few slides, right, Shawn? We got something coming up on that.
Yep.
So, but thank you for your question and participating. You know, Shawn Marie says that they can be taken out under ultrasound guidance if absolutely necessary, but do tell patients once in a while they're in for the long run. Yeah. So, I mean, ultimately pellet procedures are pretty minor. It's basically just kind of a little nick in the skin with some local medication, some numbing medication to kind of keep the patient comfortable. And, basically, like you said, it's kind of just a little bit of tunneling and kind of pushing the little pellet underneath the skin. Like you said, the first time getting the dose sometimes can be a little bit we certainly work with kind of algorithms to try to figure out the best dose for you. But like you said, we typically kind of shoot for lower, especially since they're somewhat in there for 3 to 6 months, potentially. A lot of the pellets work off of your cardiac output. So the more active you are, you potentially may kind of use them up faster. I typically put kind of 1 or 2 little dissolvable stitches in the skin just to kind of keep the skin closed and help the patient heal up a little faster. But yeah, like you said, for active people, it can be a little bit of an issue, although I think for the most part, if you get the pellet deep enough and kind of put a couple stitches and kind of brace the area, and they're not doing something because again, they're kind of usually done at the top of the gluteus area, where the top of the butt in the little fat pad, or potentially in a little fat pad in the love handle or what have you. For the most part, those aren't major stress points. So, I mean, I certainly think people need to be careful, but a full week, somewhat maybe a little bit questionable, maybe up to 2 or 3 days, and then kind of going back to stuff. But certainly for the people that are really active, I mean, most folks don't want to take a day off, let alone 2 to 3 days. So that can be a little bit of a problem. I haven't had much issue having to try to take them out, but I do know that other folks that have tried, it does make it problematic. And so from that standpoint, especially since you're kind of in there for the long haul, it's a little bit of a tough spot to be in if there's some sort of issue, which again, everybody responds to either medications or even natural supplements or what have you differently, right? You would never know. We can't predict everything that's going to happen in what we do when we treat people, right? So I guess the other thing is that there is some bioidentical, some plant-based hormone companies out there that I think especially in kind of the plant-based culture and what have you, for some folks is a little bit appealing. Whether or not they're complete, I think for estrogens, I think plant-based supplements and stuff are kind of have some evidence to suggest they're better. But in the testosterone realm, I think most of the experts kind of agree that it's really not much different. Although, again, if you're making something in a lab rather than getting it from a plant that makes the same exact molecule you make in your body, I mean, to some extent, there could be potential differences there for folks, but nothing really proven at this point.
Well, and here's I could speak for
Sure.
hours on just that topic alone. But when we come
Yeah.
to natural versus synthetic versus bioidentical, there there's so much confusion. And whether it be testosterone or whether it be progesterone or whether it be estradiol, a lot of them are isolated from plants. They're isolated from plants, and then they're manipulated a little bit in a lab to be an exact copy of what our body makes up. So bio meaning life, identical. Bioidentical meaning exactly copies of what's in our body. So in theory, it doesn't matter where it comes from. It's identical to what our body makes up. Here's a
Right.
good example that I usually use. So Premarin, I think everybody that's watching and even a lot of patients will know this. Premarin is natural. Premarin is natural for sure. Pregnant mare's urine is what Premarin stands for. Pregnant mare's urine. The drug company Wyatt Ayres impregnates horses and isolates because there's a lot of estrogen in a pregnant horse. They isolate urine from the horse, and then they will standardize it to a certain concentration of estradiol, estrone. So you want a natural hormone that's not touched in a laboratory at all, although that's touched in a laboratory actually because they do standardize it. That's natural. Well, in my opinion, it's not the best thing. Estradiol is kind of synthetic, not really, because it is come from a plant, but then we do manipulate it in a lab. So what's important is bioidentical. Let's go back to our Latin in school. Bio, life, identical. Identical is in our bodies. Premarin is not bioidentical because there is equilin in there, which is an estrogen specific to horses that is not in a human body. So I wanted to clear that up. Bioidentical. The testosterone. Speaking of bioidentical, this is another reason I like plain testosterone. So like in a pellet, it's plain testosterone. It is bioidentical testosterone. In an injection, it's testosterone cypionate. Now, the liver does have to cleave the cypionate in order to make it into testosterone, which becomes bioidentical. But there again, there's a process there, and it's not as perfect as just delivering testosterone like a pellet would or like transdermal would, which we're going to go into next. So, you have anything else on that, Dr. Wallen?
No, that's great. I didn't even know that that's what Premarin stood for. You learn something new every day. So
Well, I've
I
learned a
guess
lot
I
from
guess
you.
it's a good thing. I guess it's a good thing I don't need to use Premarin ever because I'm kind of, even
Well,
though I'm a urologist and deal with urine all the time, I don't think I'd really want to be rubbing urine all over myself.
I like to, and I used to when I first got out of pharmacy school. Of course, in pharmacy school, I mean, Premarin was, it was touted a lot in pharmacy school. Wyatt Ayres was our biggest
Right,
donor in pharmacy school,
right,
and I used to be kind of a little bit tiptoeish when I would talk to people about Premarin, but now because I really am so passionate about it, and they've kind of gotten away from teaching people what Premarin really what Premarin really means, because
yeah,
it doesn't mean a good thing. I mean, really. And if people knew that, so I just tell them Premarin is horse pee. I'm not lying. It is.
right.
And I think every doctor should know that prescribes it. I think every patient should know that it takes that. And um, you know, so anyway, I just put it out there. And I honestly, and here's me going on a little bit of a soapbox, but we are talking about hormones. I honestly don't think that one of the reasons if that's all we had, then great. But we've got estradiol to replace it. So why would we even think about Premarin? That's my opinion.
Right, right. Makes sense.
So, yeah. So we're going to talk about. Back up a little bit. I want to say. Yeah. Good. Okay. Now go to the next one. Okay. Okay. So here's what I want to talk about: testosterone topically. So testosterone is, we talked about not being absorbed well orally. There are some, special products out there, but there's a study, and I was actually part of the study. I actually wrote the study, just disclaimer. And I do own a compound pharmacy. That's disclaimer. And the testosterone was made up in my pharmacy. And it's an N of one, so it's a case study N of one only. But I will also tell you, we've seen this with hundreds, maybe thousands of patients, but this is the first study I've ever seen that it shows the actual absorption of testosterone through the skin. Now, let's be even more specific about that. What part of the skin? It's this was through scrotal absorption, so applied underneath the scrotal area, which more would be the perineum. Is that correct, Dr. Wallen? Right?
Behind the scrotum, yeah.
Like
The
underneath the scrotum,
perineum.
between the rectum and the scrotum would be perineum,
Correct.
right?
Yep.
Okay.
Yep. Absolutely.
So that's where this is applied. We talk about it being the scrotal area in our pharmacy, but really, I think a gynecologist kind of corrected me on that one time and says, well, it's probably perineum. I'm like, yes, it is. But remember, I'm a pharmacist. That's why I need to work with doctors. I don't know the anatomy like you guys do.
Right.
So we compound testosterone in a Versa-based cream, nothing special really, 200 milligram per pump. And it was applied once daily in the morning. And one thing that we've always debated with testosterone is it absorbed, and how well is it absorbed, and how often do you need to apply it. So but what this study showed is that we did a time of 0. So right before they applied it, we drew the blood. We drew the blood an hour afterwards, 2 hours afterwards, 6 hours, and 12 hours. We didn't report on 12 hours, but I will report on that a little bit later. But the study didn't report on that. The first study of this kind of, to our knowledge, I have found a study since where another pharmacy did that. So let's go ahead and go to the next slide. So what are we trying to look for? Is it absorbed? Now, I will tell you, in our clinical practice, we knew it was, because we would see patients with great lab levels after they were using their testosterone. So what else were we trying to find out? What is the proper dose? How often should it be applied? And why would I ask how often it should be applied? Well, because I will tell you, in our pharmacy, we used to talk a lot about BID dosing, so twice daily dosing. So they would take that 200 milligrams and they would use it twice a day. And obviously that increases cost, right? So we want to make sure that we can give the best results with the best value to our patients. So when is the appropriate time to draw levels? We'll talk a lot about that. Doesn't matter where it's applied. So I talked about scrotal area, but we'll talk about arm and chest, because like if you look at the commercially available products like Androgel, it talks about upper arm and chest area. Does the volume of cream matter? Meaning 200 milligrams in 5 mils, would it matter if it was 5 mils, or would it matter if it's 1 mil? So let's go ahead and go to the next slide. So here is actually the study, and it basically shows, I have to look really close with my glasses on, but it basically shows that, right after 1 hour after you got a level of 600, and with a couple hours, you've got a level of 1200. 6 hours later, you got a level of about 1300. And look at that curve. Look at how that curve is just flattening. So it peaks up and then it flattens. So I want to talk on that. So remember, we talked about the peaks after injection. So, and obviously you get a peak, any drug that you take, there's a peak and a valley, period. But what you're trying to do usually, not always, but usually is with testosterone deliveries, you're trying to get a pretty consistent level throughout the day. So what this study showed is that, testosterone is absorbed, period. I mean, we showed that it is absorbed, and we showed that it doesn't have a super high peak. We also showed that it's flatlined after 6 hours, and the level's not really going down. So it looks like it's doing a pretty good job of delivering a consistent level of testosterone over time. Now, here's what I like about the skin. Our skin is created wonderfully. We are designed wonderfully. Our skin is created to literally prevent toxins from being absorbed into our bodies. Well, when we apply testosterone to our skin, our bodies don't know it any different than it's a poison. So let's not let that poison be absorbed. So that's one of the reasons why when we don't break the barrier of the skin, you don't get that high peak, because the skin's saying, okay, I'm going to block this from being absorbed. But what it does do is it creates a wonderful delivery device, because it is only going to let so much be absorbed over time. And if you look at this study, that's exactly what's happening. So here's some of my thoughts on that. So how well is it absorbed? Well, the only way to really know that would be to put the testosterone on and keep doing blood draws over days, because here's my opinion of this based on this graph. And I didn't show you the 12 hours, but 12 hours later, it was down to about 700, I believe. We didn't publish that in the study, but, so which tells you it's following a good diurnal variation. So, my guess is that if you let it stay on the skin long enough and you didn't shower and you didn't, wash it off, that I think almost 100% of that testosterone might be absorbed. Now, there's some variables there with particle size and things, and that certain particle size of the micronized testosterone that wasn't small enough might not be absorbed. But that being said, the skin is a great delivery device to deliver testosterone at consistent levels over time, over at least a day. So what else does that tell us? If 12 hours, if we're trying to follow a diurnal variation, and 12 hours later, so they applied it at 7 o'clock in the morning, 12 hours later, their level was still 700. Then that also means that you probably don't need to do BID dosing. Now, I'm not saying that not all patients, if those patients are crashing during the middle, at the end of the day and at night, then maybe a second dose would make them feel better. But in general, you might not need a second dose. Now, let me also talk about the levels. So Dr. Wallen hit on it a little bit earlier. We both did about super physiological levels. Now, depending on what lab you read, normal testosterone levels should be at 300 to 900. Is that correct, Dr. Wallen? Depends on the lab. Is that about right?
Yeah, I mean, I've seen up to 1100 as kind of considered normal. Just again, like you said, it depends on the lab, and unfortunately, there's not great studies as far as what true kind of normal levels are, right? So,
right, and that's what I wanted to hit on, because some people, I will tell you, doctors that aren't familiar with hormone replacement, they'll see a level of 1300 like on this patient, and they will just freak out in the study. And this is what I will say. I'll say, look, when I was 39 years old, I've been, my wife and I have been, dealing with hormone replacement for 20 some years as pharmacists, and it's really what we focus on. So I was fortunate enough when I was 39 years old to get a testosterone level drawn, when I was still producing quite a bit of testosterone. So my level then was 1250. I was 39 years old. My level was 1250. So, if you were going to tell me when I'm 55 years old, I'm not 50 yet even, but if you're going to tell me at 55 years old that my normal level should be 500, I felt good at 39. So this is another thing for, any kind of healthcare provider that's watching. That's why it's important to check testosterone levels early. Even if they're not having symptoms, just like Dr. Wallen's slide said earlier, not only that they might benefit then, but also you want to know a good baseline. What is their baseline? So that's why there's a difference between what's normal with our lab levels and what's optimal. So, and that's, very, that there's a big variance there. And I will have Dr. Wallen talk about that a little bit later too, but that's what our study said. The nice thing is there was no gynecomastia in the patient, and they weren't on an aromatase inhibitor to lower their estradiol, and their estradiol was about 50, which I started thinking in my head when Dr. Wallen talked about the 20-to-1. That's about a 20-to-1 ratio, because if your estradiol level is 50, 20-to-1 would be 1,000. Am I doing the math right? Yeah.
mm-hmm.
Yeah.
Yep.
So that's about 20-to-1 ratio. So this person, now I will say this, that's why absolute numbers and relative numbers are totally different, because somebody would say, there are some doctors that would say, well, an estradiol of 50 is way too high. Well, that's why you have to look at the ratio of testosterone to estradiol, not just the real number of estradiol. And remember, men make up estradiol whether they're on testosterone or not. Men need estradiol also, not just women. In fact, when a woman's not in her luteal phase, a man's estradiol is about the same as a woman's. So anyway, next slide. So this is a 12 hours post. It just showed that their levels 12 hours was, I already mentioned, that was still 700. Now, and this is based on the chest. So look at the chest absorption. Same dose on the chest. Their level is 400. So here's another thing. When somebody says, well, testosterone is not absorbed very well topically. Well, it depends on where you apply it. So does it make sense that it would be absorbed better in the perineum than it would the chest area? Absolutely. I mean, think about the difference of the skin. The perineum area, it's a thin-skinned area. It's got great blood flow. That's one of the reasons we tell people, you shouldn't apply potent corticosteroids to the perineum, because they will be absorbed very well. Well, testosterone is a steroid, just like corticosteroids are. So it's going to be absorbed well in the perineum. So we really shouldn't be surprised about that. I think one of the cautions that we have with testosterone being applied there is many, many years ago, and I will let the expert, Dr. Wallen, talk about this. Testosterone was associated with prostate cancer. So do not apply testosterone topical testosterone to, an area that's close to the prostate. Now, that to me doesn't make a lot of sense anyways, because, just because it's absorbed there doesn't mean it's going to be systemically affect your prostate. But I also want to let Dr. Wallen talk a little bit about that. Can you comment on that, Dr. Wallen?
Yeah, sure. So I mean, the reality is, what did you say in your lab values was the lower range of normal, somewhere around 400?
Yeah, I said 300, but I've seen
Right,
labs that say 200 to
right,
800, and so
right.
yeah, so
Fair.
I said 300, but
So I guess the concern with prostate cancer testosterone used to be that there's we used to think that it was kind of pouring fuel on the fire, so to speak, right, from a prostate cancer standpoint. If I gave a man testosterone, I'd be essentially dousing the fire with gasoline, right? And so the reality is that unfortunately what we see, that thinking was to a large degree wrong, because what we see is that even for prostate cancers, there's a certain threshold where the prostate kind of stops responding to testosterone, and that threshold is actually below the lower limit of normal for most men, which is about 250 milligrams or nanograms per deciliter, right? So I mean, that's lower than most normal men would be ever. And so from that standpoint, if you're already above that, adding extra testosterone on top of that, really is not all that troublesome. In fact, there's folks at Harvard that are doing studies right now where folks are actively diagnosed with prostate cancer and have an early diagnosis that doesn't necessarily need treatment. Um, but they're being treated with testosterone replacement therapy or hormone therapy, what have you. We kind of talked about earlier, kind of we don't necessarily completely understand the hormone MyLu that kind of contributes to prostate cancer 100%, but potentially maybe it's more so dihydro versus true testosterone. Again, maybe it's even somewhat related to estrogens,
yep,
excessive,
yep.
and maybe it's all dependent on that ratio, right? The balance of again, life is a delicate balance, right? And so, maybe it's not testosterone by itself, estrogen by itself, or dihydrotestosterone by itself, but maybe it's the ratio of where these all play out. We don't know that for certain, but what we do know is, again, there's people actively with a diagnosis of prostate cancer being treated with testosterone replacement therapy. I think there's a couple slides a little bit later here, also I'll just briefly touch on it, but there is some folks also that are doing testosterone replacement therapy in men who have metastatic or advanced prostate cancer, and we can talk about that a little bit more in a few slides here. There is also another study that we'll get into in a few slides that actually shows men who had a radical prostatectomy for prostate cancer, had surgery for prostate cancer, had their prostate removed. There's actually a decrease in the recurrence of prostate cancer when their hormones are replaced after surgery. And so, again, it just doesn't show the expected results that we used to think. The classical thinking is just not really proven to be the case based on these research studies. And actually, I think that study we'll see it here in a few slides, but I think that there was about a 50% actually decrease in the recurrence of prostate cancer in the group that actually had hormone replacement therapy after their surgery because of low testosterone.
I'm excited to dive into that study in a few slides. So, one of the things I want to take away from this is that I already talked about that it is absorbed, and we still have good consistent levels. One thing is high levels permit conversion of estradiol. I want to make sure I didn't get anything. I actually already talked about all of this, but one thing I want to take away is that, so if you can find information out there, because there are still black box warnings on certain products that say do not apply to the scrotum. And I try to talk to all my patients about, we do apply it, and don't be surprised. We recommend you apply it there because it's good, it's well absorbed. Don't be surprised you find information out there that says contrary, and here's why. So I think it's very important for us to know as healthcare providers that there's information out there. Do not apply, underneath the scrotum because of the dangers of the prostate cancer. That's why it's there. So that's why I wanted Dr. Wallen to talk about that. So I warn my patients about that because there's information out there about that. So I already really talked about this. Oh, I know what I do want to talk about. I did this study actually with my twin brother who has a PhD in analytical chemistry. So he's very good about writing studies. He owns his own analytical testing company and does drug studies for all companies all over the nation, so all over the world actually. So and I asked him about the bioavailability. Well, how can we find the bioavailability of testosterone? How can we find how well it's absorbed? He goes, you know what, I've worked with lots of companies where we've tried to do that, and here's the problem. You could never ever find what the bioavailability is with the cream because you're trying to guess. You'd have to try to guess how much the patient is already making themselves endogenously. So it would be almost impossible to find out how well it would be absorbed. But our guess from this data is if left on long enough, it would be very well absorbed, almost to 100%, if left on long enough. Okay, so dosing for men, this is very variable, and it also depends on the doctor. Because how conservative they want to be and where they want their levels. I talk to some doctors that say, you know what, I don't want their level to be any more than 500. Well, if that's the case, you need to start with 50 milligram. Well, I want my levels to be 1,000 to 1,200. Perfect. Then 200 milligram would work great. I put 1 to 2 times daily on there, but I already discussed that. Once a day is probably enough. Here's a nice thing about scrotal delivery. You have less risk of transfer than you do if you apply it to your upper arm and chest area. Obviously, lots of things can come in contact with your upper arm and chest area. Not as many things can come in contact with your scrotal area. So less risk of transfer. And I will tell you, I tell all my patients, make sure your wife knows about this. And usually we just don't have an issue with it. So I do want to talk about optimal versus normal testosterone. These levels range from normal is 300 to 800. Well, look at the case of me. I wouldn't be normal at 800. I was normal at 1250. So that's my optimal level. So I think it's very important that you know that and you work with, and that, healthcare providers that dose testosterone know that to get the best results from their patients. Here's the timing of the lab. We get this all the time in our pharmacy. And I had a primary care doctor's nurse call in one time, and he had an 80-year-old patient, and the nurse was calling 80-year-old patient, the level's like 850. And the nurse called in and said, you guys may have the testosterone wrong. This guy's level is 850. This is way too high for an 80-year-old. We got to get him off this. And I'm like, okay, well, when do you draw the labs? She says, oh, he applied at 7 o'clock in the morning. We drew the labs at 9 o'clock. I said, okay, well, he's right in the peak there of his level of testosterone. So I said, how's he feel? Well, he feels great. And I'm like, well, if I was an 80-year-old man and I felt great with an 850 level, I wouldn't want you to change it. I said, look, if doctor is uncomfortable with the levels, have him check instead of 9 o'clock in the morning. Have him check at 5 o'clock at night, or tell the patient to not apply it that morning. And I know that sounds like you might be cheating, but here's the reality. Our levels are like this with our body all the time anyway. So, you have to, my point is, you have to know when to draw and how to interpret that level and how to interpret that lab. Because, if you're in the middle of a peak, it's going to be high. And but let's say they happen to, and we get this also, their level's down to 200. You guys didn't put enough testosterone in there. You guys made it up wrong. I'm like, well, let's ask the patient, when did they last use it? Yeah, they've been out of it for a few days. Well, then they're going to be back down the baseline. So, and here's another thing. Don't overreact. Okay. So let's say the patient's level is back down to 250 and they haven't applied it for 3 days. Don't increase their dose. Don't. Leave them at the same and tell them, okay, we want you to do this. We want you to come back in a month or 8 weeks or whatever, and we want you to apply it at 7 o'clock in the morning. We're going to check you at 9 o'clock to see what your peak levels are. So, and that's why, let's face it, symptoms and history are very important, not just treating lab levels. Lab levels are not black and white, okay? So you have to realize the timing of the lab and when to draw it. So shoot for target levels of 800. I think, but is that an average level? Is that a peak level? I mean, average level, if you look at what the study showed, probably the average level was probably about 800 when you look at the peak of, like 13 and the low was like 600. So, it's hard to say. We didn't do those calculations, but Dr. Wallen, do you have anything to expand on there?
I mean, I think just the target level, obviously we treat symptoms, but the reality is, I mean, I think, the higher level of research on hormone replacement, especially testosterone, the two highest requirement organs are your brain and your heart, right? And those, they say, basically around 6 to 800 is the requirements for those organs for optimal performance. So, I
Perfect.
mean, usually that's what I'm shooting for, is about 6 to 800. I mean, I think the AUA guidelines say, the top tertile of normal, but again, we don't necessarily always know what the heck normal is as far as levels, just because there's not good research on that, and who knows? I mean, maybe they did some of these lab levels. I don't know how they determined them. Let's put it that way. So
That's a good question.
the
Right.
reality is, I mean, they could have gone to Walmart and drawn everybody's testosterone. And I mean, first of all, I would argue that, everybody in Walmart probably isn't the most normal subset of the population in the first place.
Right. Right.
But the reality is that, the larger the swing in the lab, typically the less well understood it is a little bit, right? So, I mean, if you can say normal somewhere between 250 and 1100, to some extent, that just shows that we don't have a precise answer for what exactly is normal. But
Right.
again, if you're, I find that most people, if you can shoot them around 6 to 800 on average, I think pretty much all of their symptoms that they're complaining about, for the most part, go away, right? And so that's, again, getting back to the symptoms. I think that's the most important part. Obviously, again, like you mentioned, if they're at 1300 for a short period of time, or even 1500, I'm not super concerned about that. Remember, it's not. I mean, if they were 2,000, 3,000, whatever, then I'd be worried that they're trying to abuse the medication and
Right.
potentially using it wrong or something like that, or there's something weird going on. But remember, a little bit of low or high testosterone for a short period of time is not an independent risk factor for cardiovascular problems. Low testosterone is, right? And so,
Well, and on a side note
uh,
of that, right. And on a side note of that, who knows, have you ever taken a high caliber athlete and checked their testosterone, every
right,
hour for, like a week? I
right,
mean, do their levels get up to 2000 when they need that much testosterone? I don't know. I really don't
right.
know. I've never seen something like that, but our testosterone levels must vary throughout the day quite considerably. So that's one thing to think about. One thing I do want to think about too is, like, speaking of abuse, it's harder to abuse topical testosterone. For one reason is that because of the way our skin works, I was talking about being a protective mechanism, just because you double the dose topically doesn't necessarily mean you double the peak concentration. Now, my theory is that eventually all that will be absorbed, but it's still not gonna cause the high peaks because of the protective mechanism our skin has. So topical testosterone here, just to finish up on that, it's got a good safety profile. It is well absorbed, and it can be very cost effective. I know some of the commercially available products are not cost effective, but if compounded, it can be very cost effective. I do want to mention this. So you will see some doctors that will prescribe testosterone rectally. They'll apply it rectally, and as you can imagine, that's a mucous membrane, and you get great absorption, right? I will tell you, through this study, we had that happen accidentally once, and we had a level of like 4,000. A peak level like 4,000. Now, here's what's interesting, which just explains how the skin works. The level went down really quick afterwards, which tells you this: the testosterone, kind of like the nasal testosterone, it was absorbed very fast, and then the level went
Right.
down. That's why I love scrotal delivery, because no high peak, consistent delivery. It's awesome. Yeah. So topical testosterone for women. Don't have a study to show anything, but clinically, we have monitored patients for years, and 2 to 10 milligrams is absorbed the best. I like it applied vaginally. Why? Because it is absorbed, again, mucous membrane, absorbed very well there, and you get local effects. We talked about the vaginal atrophy. So, if all you're looking for is your local effects, you can just do it 2 to 3 times a week. it's great absorption. And one thing we get questions of, does it affect the male partner? Well, there's going to be some absorption. There is no doubt, but you do not have to worry about a man getting 10 milligrams of testosterone, absorbed. So it's probably not going to hurt him. So, although if women aren't comfortable with that, they can definitely apply it to skin elsewhere, inner thigh area. I don't necessarily like wrist and forearm, because then it could transfer to somebody else. And yeah, so that's it on female testosterone absorption. It's the same theory as a male topical absorbed. Go ahead. So I'm gonna definitely let Dr. Wallen comment on this a lot, since he's the expert. So PSA, we've already talked about a little bit, not much, but testosterone versus total testosterone versus free testosterone. I will tell you, we talk about free testosterone all the time, but even in my discussion earlier, we were talking about total levels, just because that's what's so common. So people are used to hearing 300 to 800 or whatever on total level. But what's important is the free testosterone level, because sex hormone binding globulin, testosterone binds to sex hormone binding globulin. There's a lot of things that will increase that. Estradiol will increase that. Corticosteroids will increase that. Birth control pills will increase that. So that means you would have less free testosterone floating around. And free testosterone is the only testosterone that can work at the receptor site. If it's bound to a protein, sex hormone binding globulin, it is not going to work at the receptor site. So free testosterone is very important. Estradiol, I think it's nice to be in there. I know there's some doctors that for their males, they prescribe anostrozole, which is an aromatase inhibitor, right away. I will tell you, with topical testosterone, I don't think that's necessary. DHT, lipid profile, CBC, CMP, vitamin D and B12, I just think are good anyway. And thyroid panel, low thyroid symptoms mimic low testosterone symptoms. It's important to have both of them. I don't think necessarily I don't think necessarily, especially with men, you should treat both the same. You should start both at the same time. Always with men, I think always is a very broad term, but mostly with men, I think starting testosterone first to get rid of the symptoms is probably the best. And then, icing on the cake would be thyroid. And I'm going to let Dr. Wallen talk about that. Symptoms, not lab levels, is so true. One thing I want to make sure that we don't miss, Dr. Wallen, is the red blood cell issue and H&H going up. And I want to make sure I talk about this right. Remember, I'm a pharmacist, not a doctor. Hemochromatosis, right?
It's interesting because a lot of people will talk about it differently. I mean, it's essentially kind of polycythemia, right?
Okay.
You have an increase in red blood cell numbers, and so your hematocrit is higher. Which, remember, your hematocrit is really just a concentration of the amount of cells, mostly red blood cells, inside the volume of your blood, right? And so it's really polycythemia. Some people will say there's a varying difference of terms used, but I think polycythemia probably is the most, because you have more red blood cells, right? And so your blood gets thicker because of that. So yeah, I mean, like you said, I mean, I think certainly some of these are really just kind of screening in the beginning. Certainly the AUA recommends, the American Urologic Association recommends a PSA for anybody over 40 before you start them on testosterone. Obviously you want to know their general health, where they're at as far as a cancer risk issue or what have you, even though we talked about that it's not necessarily a huge risk factor to start somebody on hormone therapy for prostate cancer issues. But even the thyroid, you want to know whether or not their thyroid is dysfunctional. The vitamin D and B12 are really kind of, again, screening for fatigue type issues, right? And so in my post, my panel of labs that I get afterwards, after starting someone on testosterone, it's really a testosterone free and total, estrogen, estradiol, as you have here, and then a CBC and CMP, right? And so again, CBC is going to cover that hematocrit, panel, or portion of the labs, and then the CMP kind of mainly for liver function and just checking in on the other functional systems, make sure their electrolytes are mostly normal and their kidney function still good. But yeah, I mean, I think that the reality is those kind of four main labs afterwards are kind of the biggest ways to follow people and make sure you keep them safe afterwards.
Perfect. So
and then sorry, just one other thing other than that.
Yep.
Then I would typically do just kind of the yearly screening for PSA with an exam as well. I mean, I don't typically do any increased PSA screenings because somebody's on testosterone at this point in time. I mean,
And
I
let's
just don't find it valuable.
right. So let's hit on that a little bit. Is it true that sometimes testosterone will increase PSA acutely right after starting treatment?
I mean, it can be. I don't think it always does. I mean,
Okay.
certainly there are a lot of situations where again, I think we've had the discussion before where to some extent, remember the prostate tissue. PSA is directly related to prostate tissue. It's prostate specific antigen, right? And so certainly we know as your the amount of prostate tissue gets more voluminous, the PSA tends to be higher, so it can be elevated for non-cancerous issues. There's other things that can cause the PSA to be elevated as well, but certainly remember prostate tissue does respond to testosterone, and so it wouldn't be unheard of if you had a little jump in the testosterone. However, significant jumps are a little bit different story unless you've kind of skyrocketed their testosterone, which I have seen before as well, not in my hands, but from some other folks who have consulted me about issues they've had. But so if you skyrocket the testosterone, certainly you might expect a little bit bigger jump in the testosterone. But for most folks, it really probably shouldn't jump more than maybe a half a point to a point, or more, or less. Just because you've started them on hormone replacement therapy.
Perfect. I'm glad you cleared that up. So another thing on polycythemia. So when patients live at altitude, their
Right.
their their hematocrit and hemoglobin will go up, right?
Yes. Yes, sir.
And so do we when they have a high because with testosterone, let's just typically a lot of times when you have a high H&H and they're on testosterone therapy, we'll tell them to give blood, right?
Correct.
And then a lot of times they'll feel like crap for 10 days afterwards. So my
Unfortunately,
analogy was, or I've been taught this, I didn't make it up, was, patients that live at altitude also have the same thing happening and they have an increase in red blood cells, right? And we
correct.
don't,
As a response to low oxygen in the atmosphere.
right.
Yeah.
And we don't tell them to give blood. Can you expand on that, please?
Right. I mean, I think certainly if your hematocrit is over 54%, typically the AUA does recommend phlebotomy at that point. Quite honestly, I think that it's not a huge percent. I mean, I would say maybe roughly 20 to 30% of folks potentially have some issue with hematocrit as they are on therapy. I think certainly, the longer acting forms, the injections, the pellets and stuff can be a little bit more of a problem. Certainly topicals and shorter acting forms. I think, certainly even the nasal spray tends to be less of an issue because it does, kind of mirror our normal body processes a little bit better, I think. And I think that probably is part of the reason why. But I mean, I think the bigger problem with hematocrit, again, we talked about the hematocrit is really just a measure of the blood thickness to a large degree, cells over volume, right? Concentration, and so people that live at altitude, they're used to that thickness of their blood kind of continuously, right? It's not an acute change.
Right.
And certainly for folks who are chronically on testosterone, you could argue that, chronic therapy, that's probably not necessarily an acute change if you left it alone either. However, again, we talked about kind of closing of the arteries and veins and stuff, and potentially for folks who have, some lipid or cholesterol dysfunction and have, potential vascular disease, if they have an acute change in blood thickness, that could certainly cause, a problem to where, some of those blood cells kind of just clog up into that narrowing, like kind of like more sticks getting caught up in a dam as they're going down the stream, right? And so from that standpoint, I think that's the biggest portion of the concern is kind of that acute change in hematocrit and concentration or blood thickness, potentially causing either blood clots or heart attacks or strokes or et cetera because of that. That would be a very interesting study to do to see, and it's not been done, But it'd be a very interesting study to do to see, what the risks are of an acute change in your hematocrit level with initiation of hormone therapy, plus minus phlebotomy to kind of thin things
Right.
out, versus kind of your long term, once you get kind of stabilized and are more used to that concentration or that thickness, presuming you don't have other predisposing, vascular disease or narrowing, is it really a big issue?
Right. And
Again, the
and that'd
studies have
be
not been done, so we just don't know. But that
right.
would be kind of hard to do. But it would be interesting to know. I mean, certainly,
So
because
three
that
options.
would be more similar to your example of somebody that lives at altitude who's kind of continuously at that
Right.
level and kind of just lives there all day long versus an acute kind of change because of the replacement of the hormone.
So 54% hematocrit is the number that is recommended, is what you're saying, and you could always lower the dose testosterone, and you could have them get a phlebotomy first and lower the dose. But 54%, I will say that I've seen doctors that say 50% is the maximum, the number, and I just think that's super conservative. So I like hearing the 54% because I think that's probably more realistic, because there's a lot of men that float around the 50 to 51 range, and I think are probably doing okay. So let's go ahead and go to the next slide. So women, not much different, except I would throw a progesterone level in there. I didn't talk about DHEA, and we're not talking necessarily about DHE on this presentation, but probably should have put that in there for men too. A progesterone for women. There's also you can see a lot of research. There's been a lot of research done about progesterone for men also, but we're talking about testosterone today, so we won't get too much into it. But women is pretty much the same. You're just treating different levels. I think when you look at women, if they do have a thyroid issue going on, usually women will probably get a bigger bang for their buck balancing their thyroid first. And I have a presentation out there on thyroid if you guys want some more information on that. And then look at testosterone optimization for women. You have any comments on that, Dr. Wallen?
No, I mean, I think I agree with pretty much with what you said. I don't tend to use or consider progesterone much for men, but yeah, I mean, I
Yep.
think, thyroid certainly does play a role. I mean, obviously, I mean, look, Synthroid is one of the highest grossing medications on the market ever, right? And
Yep.
so, and actually, I think we'll get into this a little bit more, but it doesn't even actually contain the actual active form of thyroid hormone, right? It's
That's
not
correct.
it's not T3.
Right.
So it's interesting because there's a lot of people that would argue that natural supplements like NP thyroid or such that actually have T3 in them, or these natural extracts and byproducts could potentially be better. But I'm not a thyroid expert, but I do some thyroid replacement for folks that need it. I mean, certainly, again, just like the adrenals and the testicles and ovaries produce testosterone and estrogen and progesterone. I mean, your thyroid, there's a reason you had normal thyroid function and hormones when you were younger, right? And so, certainly as we get older, again, kind of keeping weight off is always somewhat of a concern for people and somewhat of a problem. And certainly thyroid hormone plays a decent role in a lot of different processes. Certainly, you do have to be careful. I mean, obviously, if you overdose someone on thyroid medications, you can, cause significant heart problems or, other badness that you don't
Yeah,
want
for
to
sure.
do, right? And so it's just like anything else. It's got to be physiologic and to some extent, again, in my hands, I always try to be as natural as possible if
Right.
if possible and
Yeah,
necessary, right?
not super physiological. Yep. All right, let's
Right.
go to the next slide. All right, so now we're going to get some case studies. And so this one, 52-year-old male, erectile dysfunction. So what do we prescribe for erectile dysfunction? We prescribe Viagra, right? And if you look, this patient is on Viagra. He's also got high cholesterol, so he's on atorvastatin. He's also got depression, so he's on fluoxetine. He's also got high blood pressure, so on lisinopril. Testosterone can treat all those things. So symptoms started within the last few years. Wife recently had her hormones balanced and refers him to the same doctor. So hormone levels come back. I didn't put the actual lab numbers in there. They're just general. I just want to put the general numbers in there. So, total testosterone 250. On this lab, it was normal is 160 to 726. So he's normal on the low end of normal. Free testosterone is below normal. TSH, he's on the low end of normal. Free T4, low end of normal. Free T3, low end of normal. Estradiol 19, DHEA 85, low end of normal. So start testosterone and just a little bit on DHEA. DHEA is an anabolic hormone or an androgen. They call it an androgen. I don't like that term because women make it too, but DHEA is more specific to the adrenal gland, producing adrenal gland to help us respond to stress. Typically, men that have low testosterone and women that have low testosterone, especially when they're older, will have low DHEA. So a lot of times men will feel better on testosterone and DHEA. So this guy started on 200 milligrams topical cream, testosterone, and 100 milligrams SR capsule, sustained release capsule, QH. I said QHS, and that should say QAM. Remind me to fix that slide. DHA should be dosed in the morning because that's when we produce it in the adrenal gland. So sorry about that slide. So 2-week report, less depressed. This is very common, by the way. Less depressed, more energy, libido increase, erectile function resolved. Think about it. He doesn't need Viagra anymore. Waking up in the morning, erections again. First time in many years, can work out in the gym again. Wife calls the doctor to report great results. Many times, the wife has to tell the husband to go in. What happens a lot of times is we balance the wife's hormones, and we warn them. It's like, they're in their 50s. I'm warning them, like, well, how's your husband doing? Oh, he's gained weight over the last few years. And I'm like, well, you better tell him to get ready. And I really mean that in a lot of ways. So you look at his labs come back, testosterone level 900. So yeah, it's on the higher end in this lab, but we've talked about that enough. So don't freak out over 900. His DHEA is on the high end of normal. I like to see that. Cholesterol's down to 198. Can we take him off atorvastatin? Remember the side effects of atorvastatin. Liver issues and rhabdomyolysis with muscle pain. How many patients that have low testosterone are on a statin and they have just fatigue and weakness? Now that could be caused from low testosterone, but it also be caused from that medication. So let's try to solve the problem instead of treating the symptom. So I've already talked a lot about this, that the half-life of testosterone is short. So now when I say that, the half-life of testosterone is short, but the skin's a good delivery device. So it's not necessarily, it will provide a consistent level. But, realize the time in the lab. So, time of the dose and when the lab was drawn. But as the patient, okay, his level's high. Is the patient having symptoms of oily skin or acne? That's usually the first symptom that they will get is oily skin or acne. The same for men and for women. Women seem to be a little more sensitive for probably obvious reasons. If you overdose from a little bit of testosterone. The great news is that is all reversible. So you warn them, if you get oily skin, get acne, talk to us and we'll talk about decreasing your dose. So his thyroid is not necessarily optimal. Remember, there's optimal versus normal. Later on, we could, maybe address that if we want to make him feel optimal. What are some things we can do? Discontinue sildenafil, fluoxetine. Usually fluoxetine you can't do within 2 weeks, but let's say 6 months later, he's not depressed, or 8 or 9 weeks later, we can maybe take him off fluoxetine. After he loses weight, loses 20 pounds, hypertension is resolved, discontinue lisinopril. So we gave him one drug that makes him feel much better, and we got rid of 3. It's amazing. So, and we also talked about diabetes. We could, there's patients in there that can get off diabetes drugs. Dr. Wall already talked about that. So you being the doctor, you want to discuss this case a little bit, Dr. Wallen?
Yeah, I think it's classic. Certainly one of the big problems with kind of mood disturbances is fatigue and kind of insomnia, and certainly we know testosterone and these hormones are very good for that. But you mentioned, maybe we didn't really discuss it specifically, but certainly, testosterone is to some extent a vasodilator as well, right? And so, from a standpoint of helping his erections, but also helping with the hypertension or the high blood pressure, that certainly does play a role. Obviously losing weight makes a lot of things better for a lot of people, right? And so, not that we're titrating their again, not titrating their hormones to super physiological levels to try to just, get them to shed pounds, but it's the way that these molecules work, and that's part of the reason that we're normal, kind of functioning and kind of normal weight as we are younger, and tend to have more issues kind of with weight gain and such as we get older, right? And so,
Right.
there's a ton of things that, again, it's funny because, in Western medicine, we throw any number of pharmaceuticals at people for common symptoms, signs, problems that we know are potential risk factors. But, again, it's a struggle to kind of get people to just think about, replace, if you were up here when you were younger and you did one of these things with your hormones, and all we do is kind of keep you at an even keel, steady state throughout your older years, and kind of bridge that gap. I mean, a lot of these problems that we see with older age and such, go away, which, intuitively just makes a lot of sense.
Absolutely. And it's all about quality of life too. I mean, for sure.
Correct.
All right, next case. Okay, here's a female, diagnosed of 49-year-old, diagnosed fibromyalgia. Let me just stress this over and over and over again, whether they're 18 years old or whether they're 49 years old. Anytime there is a cycling issue, cycles are becoming more irregular, and she has fibromyalgia. Let's just add headaches in there. Okay, she has headaches with her cycles. She doesn't lack Emitrex, okay? If it's a cycling issue, it is hormone related, period. So instead of treating it with a drug, why don't we fix the problem and try to work with her cycles? That's a whole other topic on progesterone. But still, if it's a cycling issue, it's hormone related. Let's just think that. So gained 15 pounds over the last few years, mostly around the middle, classic testosterone. I will tell you, if you've done this long enough, you can start looking at men and women, mostly men, because their builds are different. You can just look at the classic 50-year-old man that's been thin his entire life. All of a sudden, he's got this weight gain right around the middle. Classic low testosterone. Then you ask him, how's your cholesterol? It was fine until about 5 years ago. Then I had to go on cholesterol medication. It's like, yeah, okay. You ever had your testosterone checked? No. Anyway, I'm just stressing just to watch for these things in your guys' practice. Hair is thinning, decreased libido, decreased energy, depression. Recently started citalopram. Recent diagnosis of high cholesterol. There we go again. Started atorvastatin, feeling aches and pains. Is that the atorvastatin or is it because lack of testosterone? So now she's taking an opioid to treat those aches and pains and on gabapentin. Painful intercourse. So let's realize when a woman talks about painful intercourse, there could be multiple reasons. Or if they have low libido, why do they have low libido? Well, they might have low libido because they have painful intercourse. Why do they have painful intercourse? Well, because they have vaginal dryness, possibly. If that's the case, that needs to be addressed. And testosterone can help for vaginal dryness. We talked a little bit about that. But if they have vaginal dryness, you have to address that issue with topical estrogen cream immediately if that's a complaint, in my opinion. I'll let Dr. Wallen talk about that too. But obviously, these are all hormone-related issues, but look at some of the drugs that we prescribe there. So check hormones. Patients currently taking levothyroxine, which is T4. It is not actually the active form of thyroid. Hormone levels come back 17 for testosterone, TSH 2.9, free T4 1.5. So her free T. This is a very common profile. Her free T4, because she's on levothyroxine, is right in the middle end of normal. That's normal. That we see that commonly. But her T3, if you look, is on the lower end of normal. Go ahead, Dr. Wallen, if you want to discuss that at all.
Yeah, I mean, I think you hit the nail on the head. Certainly, especially postmenopausal women, estrogen is huge for preventing UTIs, preventing vaginal atrophy and dryness and pain. Again, pretty much all of the tissue in the bladder, urethra, pelvis is responsive to estrogen, right? And so, kind of even the risk profile, folks used to think with, I mean, again, we're talking about vaginal estrogen creams. We're not talking about, systemic hormone replacement at the current moment. But, the reality is the risk profile, even from a breast and if they still have a uterus, breast and uterine cancer standpoint is significantly low.
Right.
The amount of estrogen that's actually absorbed I know a lot of oncologists said that, I've asked them a few times, hey, is it okay if, if I use this cream in so and so or what have you?
Right.
Even when their estrogen receptor is positive on their previous breast cancer. I mean, the systemic absorption is so significantly small that it just doesn't play a role. And so, from that standpoint, again, whether we're throwing a bunch of man-made substances at them, or if we're just replacing their normal hormones that they had before when they didn't have these problems, I always go back to that because I think that plays a big role, and
Absolutely.
it just makes sense.
And it's not that estradiol is not absorbed vaginally, because most drugs are absorbed very well vaginally. It's just that we use a lower dose, a lot lower
Small
dose.
dose. Right,
Yep.
right. Thank you for
Good.
correcting me.
You're welcome. That's the pharmacist in me. That's really, I'm a pharmacist,
Hey,
not a
listen,
doctor.
listen. It's a team, right? It's a team.
Right, right. So her free level of testosterone is low. We talked about total versus free testosterone already. We talked about the thyroid and testosterone symptoms mimic each other. That's why you have to check both. TSH versus free T3 versus free T4. I could do a whole presentation on this alone, but free T3, I'm hitting on this because this does matter about testosterone. It is pertinent because all the hormones work together. They work in a symphony, and so it's important to balance all the hormones and know how to balance all the hormones, not just testosterone, if you want your patients to feel optimal. So TSH is a pituitary hormone. I know it's the gold standard of treating thyroid, but it's a pituitary hormone. It is not a thyroid hormone. Think about what we're talking about with testosterone. We check levels of testosterone, right? When we're monitoring testosterone therapy, we check levels of testosterone. We don't check FSH or LH. We check testosterone. So it's kind of the same analogy with thyroid. Again, for the purposes of this presentation, I don't really have time to get into it, or I don't want to take time to get into it because I know you guys are busy. I do have another presentation just on thyroid if you want more information about that. Free T3 is the more active form of thyroid. Her levothyroxine is normal. Her T4 is normal. We want her T3 to be normal. You have to convert T4 to T3 in order for the thyroid to be the most active. She's obviously not doing that very well. That's very common in a lot of patients. Multiple reasons: lack of selenium, lack of iodine, stress, alcohol. Many different things cause that. Aging causes that. So she might benefit from some T3 therapy along with her T4 therapy. But she does have low testosterone symptoms, also low libido, although low thyroid can cause low libido also. Testosterone 2 milligrams applied vaginally once daily. Add some T3 and a sustained release capsule. T3 has a very short half-life. So if you dose it in an immediate release form, you might need to dose it twice a day. That's why I like a sustained release form. Recheck everything in about 8 weeks. DHEA, I just wanted to mention it. We talked about it already. It supports adrenal function. Could probably do better with some DHEA. Progesterone, anytime there's cycling issues, progesterone has to be looked at. But progesterone helps support sleep. It actually is metabolized into 5-allopregnanolone, which is a modulator of GABA, which helps us to sleep. And we give prescription medications that actually modulate GABA, and not the progesterone is not a prescription necessarily. It's just more of a natural way of doing that. So any of your patients that can't sleep, take progesterone. Go ahead and go to the next one. 8 weeks later, free testosterone is 5.1, which is above the normal. Free T3 is 4.6, which is right at the upper end of normal. Free T4 hasn't moved. TSH down to 0.25. She doesn't have any oily skin, no acne, no symptoms of hyperthyroid, which would be hot flashes or tachycardia. And remember, T3 is a short half-life. So if you check your levels, 4 hours later, it's going to be down. So remember, treat symptoms, not patients, and know about how to interpret the labs based on dosing of the drug. She feels much better. Her cholesterol is lower. Pain levels are decreased. Losing weight. This is a very, very common. So think about some things we can do. Stop the atorvastatin. Stop the citalopram. Citalopram decreases, libido in itself. Atorvastatin can cause pain and fatigue. Intercourse no longer painful because the vaginal dryness is resolved. Remember, treat problems, not symptoms. What do you got to add to this, Dr. Wallen?
I think you nailed it. I
All
don't have
right. All
anything
right.
to
Let's go. Let's go. This Dr. Wallen.
Oh
Let's
yeah.
talk about this slide then.
So this is what I was talking about earlier, as far as kind of concerns with hormone therapy. This one specifically relating to prostate cancer, right? So this was that study that I referenced earlier in the talk about basically prostate cancer and biochemical recurrence. Remember, which is folks after they have their surgery or whatever definitive therapy. These guys were there's 570 of them that had radical prostatectomy surgery for prostate cancer, and they were followed for 3.5 years afterwards. And you can see here that actually in the group that had a hormone replacement, only 7.2% had high biochemical recurrence versus 12.6% in the control group that did not have testosterone replacement therapy. So again, not only does it refute the fact that they're having worse outcomes with hormone replacement in the setting of prostate cancer, but it also actually these guys did better. And
Wow.
so just a quick aside there. That's one thing. If you want to flip on to the next slide there, this one is actually an article from Dr. Abraham Morgenthaler, who's at Harvard. He's a urologist up there, and is probably one of the biggest experts in the United States as far as testosterone therapy. And he's actually, treating again, kind of quality of life. We're not treating the prostate cancer, but he's actually treating folks for quality of life problems. Because remember, for metastatic and advanced prostate cancer, one of the biggest things that we typically do for these patients is that they get androgen deprivation therapy. They get whatever combination of chemotherapy medications or immunotherapy or other types of medications to basically remove all of the testosterone from their body or block its production. And so, obviously that creates a whole slew of side effects for these patients, that we've already discussed, all the symptoms of low testosterone these guys have, including, to some extent, potentially an increased risk of cardiovascular morbidity mortality because of that, right? And so they come in with fatigue, they come in with bone pain, they come in with this. And, certainly, unfortunately, metastatic prostate cancer, I mean, the average lifespan is about 5 years for these folks, which is, longer than other cancers with metastatic disease. But even so, at some point, he's had, this was a case series, I think, of 3 patients, but at some point, you kind of have to discuss quality of life issues with some of these folks.
Yep.
And actually, even in this case series, none of these people actually had significantly worse outcomes because of their prostate cancer. Yeah, their PSA maybe have gone back up a little bit, but it's not like they had, significant, poor cancer outcomes because of being started on hormone replacement therapy. If you want to flip onto the next slide, I think this talks about um, concerns about increasing or worsening urination symptoms. And this goes back to that medication finasteride that we talked about earlier, which basically blocks the production of dihydrotestosterone, supposed to kind of limit the growth or kind of quote unquote shrink the prostate, which there are some studies that show, if you do it for 6 months or longer, potentially you'll see about a 30% decrease in your prostate volume. The reality is I think that when we've already talked about all this slew of symptoms that low testosterone causes, including, risk factor for heart outcomes, including, potentially worsening or creating dementia problems, et cetera. Why would I, basically take a hormone that's natural to the body away from you rather than just fixing the plumbing issue in your prostate? And so, the problem with the prostate is that it does surround the little tube that men pee through, the urethra. And so as it gets bigger, as we get older, we know it tends to get bigger as the older we get. In fact, 90% of guys from autopsy studies who are 90 or older had a big prostate, right? But the reality is that, again, if I'm going to block a hormone that works in your entire body for the issue in your prostate, it just doesn't make sense to me. Why not fix the prostate problem and increase the channel diameter or what have you to what it used to be before your prostate got bigger, and allow you to have the testosterone that your body wants and needs.
Right. It's an actual physical issue.
Right. Correct. It's a
So
physical issue because of
right,
compression of the tube, because
right.
of
Makes total
the
sense.
increased size of the prostate. Right.
And that's where
So
a good urologist like you comes in.
right. On to the next slide. I think there's one more here. So actually two more slides. These both talk about fertility issues, right? And so this first one here just talks about most guys. You can see here basically in this study, 100% of the guys after they stop testosterone were able to recover their sperm production. Because remember, we talked about how it tricks your brain into
Yep.
basically shutting down sperm production. We also talked about how the nasal forms and these shorter release doses potentially kind of avoid this. But certainly, if you're using testosterone, and certainly if you're using testosterone or you're prescribing testosterone for patients that are of childbearing years and are interested in having kids, you certainly got to think about this. But this just shows within 6 months, 2/3 of them had their sperm back. Within 2 years, pretty much everybody had them back. So, and then flipping on to the next slide is the final one about fertility issues. Basically just shows a couple of regimens that if you're on testosterone, because either the three times a day nasal spray didn't work for you or what have you, these are some other regimens, including HCG and FSH, that could be potential options to kind of keep the sperm production going even while you're on the hormone replacement.
Let me also hit on that too, because HCG is an injection. We've talked about injections already, about some of the disadvantages of them, but also HCG can be kind of expensive. There's been some new regulations passed over the last year with HCG. One of the things it does the same thing is clomiphene. Clomiphene does pretty much the same thing as HCG. It's orally dosed, and it can do the exact same thing. So 50 milligrams once a day usually. Is that, and are we there? Well, that's it. There we are. So thank everybody for joining in with us today. Dr. Wallen is just a wealth of information. I learned so much, after he presents. So thank you so much for being on, Dr. Wallen.
Thanks for having me.
Yeah, and this is all recorded, just to let you guys know. So anybody that wants more information, we're going to have it up on our YouTube channel, and we'll have it edited on our YouTube channel. You guys can share it with others, watch it again. So please stay tuned, because you'll find it. It'll be on our Facebook page and the Mosaic Professional Pharmacy YouTube site, so you can after the edited version is up. So thank you all for joining in. I really appreciate the presentation. A lot of good information over 2 hours, and I think Dr. Wall and I both have a passion for this subject, and we could talk about it for 8 hours probably. So thank you all for joining in. Thanks, Dr. Wallen.